Okay, so today's session will be, we are going to continue the strabismus. So we stopped the last time at the management of strabismus. And today we are going to tell what will be the lines of management of strabismus, including the medical and the surgical lines. And then we will discuss the pediatric ophthalmology. So what are the lines of management of strabismus? The strabismus can be managed according to different modalities depending on the etiology and depending on the age and the cause. So it will be in the form of non-surgical modalities and surgical modalities. The non-surgical will be the glasses prescription, the amblyopia treatment, the prisms, and the orthoptic exercises. While the surgical management will be weakening procedures, strengthening procedures, and the combination of both and different types of other surgeries for A and V pattern or the alphabetical pattern. And finally, the botulinum toxin injection as a temporary surgical relief of strabismus. So let's start by the first method. So it will be the amblyopia treatment. What is the amblyopia? Let's first have some basic concepts about the amblyopia. Amblyopia is a diminution of vision that occurs during the amblyogenic period. And what is the amblyogenic period? It is the first or early years of life. These are the early years where the visual development occur. So if there is any interruption to the normal sensory pathway or normal motor pathway, this will result in the development of amblyopia. And and this will be due to interruption of a stimuli. So basically, it is usually unilateral, like it is when there is cessation of the visual stimuli or abnormal visual stimuli to one eye. This will result in that the brain will neglect this eye. So this will result in what's called lazy eye. Actually, it is a lazy brain rather than a lazy eye. So it is mostly unilateral. However, it can be bilateral as well. Do you hear my voice clear? Okay. Okay, so let's continue. So it is usually unilateral, but it can be bilateral. And how can it be diagnosed? It is diagnosed when there is diminution of vision, which is beyond the expected level of ocular pathology. Like if you have a very minimal ocular pathology, however, you find that the visual acuity is severely impaired. We commonly encounter this scenario when we find patients who have a large error of refraction of like -10 or -20. And when you correct them by glasses, you still see that they cannot see by glasses. So why they cannot see by the glasses? Here you can expect or you should suspect the presence of amblyopia because the diminution of vision is not corrected even after correction of the cause. So speaking about the cause, what will be the causes that may result in amblyopia? Basically, they are ocular pathologies that will interrupt with the sensory and or motor visual development of the eye. So if there is a strabismus that will cause ocular misalignment, this means that one eye will not receive the visual impulse as the same eye. So in the normal eye, the image will fall on the fovea, while the other eye, the image will fall on extrafoveal site. And of course, the extrafoveal site will have poor visual acuity or poor resolving acuity rather less than the fovea. Also, the anisometropia, if there is error of refraction between both eyes, which is more than 3.5 or 4 diopters, this will result in that the brain will tend to neglect the blurry image which is coming from the from the more ametropic eye. High refractive error, even if it is bilateral. Like if there is bilateral -10 diopters in both eyes, so the brain will receive a blurred image from both eyes. There is no preference here. So both eyes can undergo amblyopia. So this can occur. And those patients have normal cortical visual development. So then the problem is not in their brain. The problem is in their eyes. Yes, their brain is lazy or their eyes are lazy, but this is not due to pathology in the brain. It is due to pathology in the eye. Okay. Wa alaikum assalam, Dr. Atif. Yeah, thank you for asking. Okay, so regarding the types of amblyopia, what are the types of amblyopia? Or we can also say that what are the reasons of amblyopia? It can be a sensory deprivation amblyopia. So the cause here is purely sensory. The cause here is that there is no sensory stimulation to the eye. Due to any reason like complete ptosis, like congenital cataract, like optic atrophy, like macular scar, all these can result in sensory deprivation amblyopia. Also, as we just mentioned, the anisometropic amblyopia and the strabismic amblyopia, which are considered to be the commonest cause of amblyopia. Anisometropic amblyopia and strabismic amblyopia. There is another kind, which is less common, which is isoametropic amblyopia, which I just mentioned that this will be due to bilateral error of refraction, high error of refraction in both eyes. And there could be a meridional amblyopia, which will result in amblyopia in a specific meridian, which happens in case of high astigmatism. So is the amblyopia common disease or uncommon? Unfortunately, it is common disease. Like 3 to 5% of children are affected by amblyopia. So in order to prevent this disease from happening, and because actually if it happened in the embryogenic period and the child grow up, actually there is no treatment after all. If in the adulthood there is no treatment, so the better is to prevent or to cure in as early as possible. So how can we detect it? First of all, by visual acuity. Depending on the age of a child, as we mentioned in the last lecture, depending on the age, we can do visual acuity testing and using either optotypes, which can be some like K picture or some symbols or HOTV test or Snellen chart, depending on the age. So in this test, what will be the suspicious of having amblyopia? The suspicious is what's called the crowding phenomenon. What is the crowding phenomenon? If you present a single optotype like this to the child, he will score well. He tend to respond correctly. But if you present this optotype in a row, in a vertical row or in a horizontal row, he will tend to score less. He will not be able to see less because of the crowding phenomenon. So if you, in those patients, if you are going to test them the visual acuity, don't use a single optotype, because if you do so, this will underestimate the degree of amblyopia. So if the child could have, for example, a visual acuity of 660, but due to that you use a single optotype, you measured it as a 618 or 624. Okay, so this is this is very important to detect the presence of amblyopia. Other tests that you should always record the power of any current spectacles. So to exclude the presence of anisometropic amblyopia, do subjective refraction if the age permits, or if doesn't permit, if a child is young, you can do cycloplegic retinoscopy. So the visual acuity is just one function, but you also know you need to do other functions like a testing of the stereopsis and binocular fusion to test for sensory development. This can be done by the Worth-Ford test. Try to look for the cause, which you cause the amblyopia, like doing external examination for ptosis or orbital hemangioma or lid hemangiomas or strawberry nevus or any other lesion that may obscure the visual axis. Also try to check for the presence of afferent pupillary defect to exclude the presence of optic nerve insult or visual pathway insult. Anterior segment examination for any media opacity like congenital cataract, like any presence of corneal scar. Do motility and ocular alignment to exclude the presence of strabismus. And of course, finally, to do the fundoscopic examination. The fundus examination to exclude any posterior segment pathology. So those are the how we assess a patient with amblyopia. Finally, how would we treat? If we deem a patient as amblyopic patient, how would we treat? Of course, the first thing is to treat the cause. So treat the cause of the amblyopia. If there is cataract, a significant cataract that will cause amblyopia, this should be removed. If there is a complete ptosis, it should be corrected. So treatment of the cause if possible. Then the only proven treatment for amblyopia so far is the occlusion therapy and what's called penalization. What is meant by the occlusion therapy or part-time occlusion? This is just by make it occlude the lazy eye. This will cause, or sorry, occluding the normal eye, so that we force the patient to use the lazy eye, and encourage the patient to engage in activities that will stimulate his vision, like drawing, like reading. So it is not to cover the eye and tell the patient to go to sleep. No, we need this patient to force him to use his eye, his lazy eye. A full-time occlusion or occlusion of the whole day can lead to what's called reverse amblyopia, where the normal eye may undergo amblyopia. So the standard now is the part-time occlusion. Another way, if the patient is refusing the patch, is to do what's called penalization or atropinization, which is shown to be as effective as patching. So basically, we are putting atropine eye drops in the normal eye in order to make it blurry. So we force the patient to use the amblyopic eye. So how much time do we do this? How much time do we do the occlusion therapy? There were numerous studies that discussed this. So one of them, there is a study that were conducted about the effect of the amblyopia, about the occlusion therapy or patching in the children. So it was this study recruited a group of children and put a patch of 2 hours per day. And after 5 weeks, it showed that there is improvement of the visual acuity of Lugmar about 0.07. So the study divided these children into severe amblyopes and moderate amblyopes. The severe amblyopes were further subdivided, so some of them received full-time occlusion and others received 6 hours occlusion per day. And after 4 months, it was found that there is no difference in the visual outcome. On the other hand, the moderate amblyopes received, some of the group received 2 hours occlusion per day, while the others received 6 hours occlusion per day. And after 4 months, again, there was no difference. By this study, we know that the optimum management or optimum duration for patients who have severe amblyopia will be 6 hours, and for patients with moderate amblyopia, it will be 2 hours per day. Okay, so this will be how would we treat those patients. And we continue the amblyopia therapy until the patients will report no improvement of the visual acuity for 3 months. So if after 3 months there is no improvement, so this can be an indication to stop the amblyopia therapy, and there is no visual acuity which is expected to, or there is no recovery or no further recovery is expected. When should we do, or at what age can we try to do the amblyopia? Well, according to the studies, we can do even up to 16 years old. Okay, so this will be the management of the amblyopia. The next thing, or the next topic, or the other lines of the treatment of strabismus, are the glasses. Okay, let me show you what is considered severe amblyopia here, and can we just do 2 hours a day for severe amblyopia? Well, there is the classification. They classified the amblyopia into mild and moderate and severe. So mild is usually defined when the visual acuity is between 6.9 to 6.12. Moderate is between 6.12 to 36, and the severe is when the visual acuity is less than 36. Okay, and according to the study, 2 hours is not enough for severe amblyopia. Well, if the vision not improved after 3 months, we can't do anything. There is, you should try the amblyopia treatment. For most of cases, it will, if it is no visual acuity is improving within 3 months, this means that it is a dense amblyopia or it is a deep amblyopia, which will unlikely to improve. So you just treat the cause. Just if the patient needs a refractive error, if the patient needs a glasses, you prescribe him glasses. If he needs strabismus surgery, you do him strabismus surgery. So the end point is that there is no further improvement. As we just mentioned in the last lecture, when we treat the patient with a strabismus, when should we do strabismus surgery? This should be done after management of amblyopia, after treatment of amblyopia. How can we judge that we treated the amblyopia? By no further improvement after 3 months, whether the patient improved or he didn't improve. As long as the visual acuity is still or stand still or it is constant for more than 3 months, this will be an indication for cessation of amblyopia therapy and to go to the next step of management, whether it is strabismus surgery or not. Okay, so the other management or the other lines of management will be the glasses. So you may ask, when should I give the glass to the child? Well, it will be as soon as possible. Actually, if you may be surprised to know that the most cause of reluctance of wearing glasses, not the child himself, it will be the parents. The parents don't just accept that the child should wear a glass and they seek a second opinion and try to ask here and there and everywhere, trying to look for a more a more appealing solution. But actually, this is the problem. So it starts by convincing the parents that the glasses is very crucial for the management and to prevent him from the amblyopia destiny in the future. So when should we give this child? As I told you, as soon as possible. Should prescribe the glasses as we can't give it, of course, to a preterm child, but as long as the child is even in the few months can wear glasses in front of his eyes, which will affect the outcome of the vision tremendously. Another method for correction of the amblyopia will be the prisms. So, or not the amblyopia, it is the strabismus. So when should we prescribe prisms? We mentioned in the strabismus lecture that prisms can be useful in treatment of paralytic strabismus and the restrictive strabismus. So we do so for patients with vertical diplopia, like in thyroid eye disease or like in sixth nerve palsy with horizontal diplopia, but they're unlikely to correct that torsional diplopia. So they are used mainly for the horizontal or vertical diplopia for small degrees, like 5 to 6 prism diopters. So it will be we can have different types. So we have the regular prism or conventional prism that can be incorporated into the spectacles. We have this thin sheet of plastic prisms. We just studied about it in optics. Does anyone know what this prism is called? Yes, exactly. It is the Fresnel prism. So a Fresnel prism is a thin plastic sheet of prisms which is clipped on the back of the glasses, which can be easily put and removed for easy use. Okay, so in this case, our prisms are usually done for patients with strabism, for paralytic or restrictive strabismus, because the angle is not still stable. We said that we wait for surgery in those patients for 6 months. And during these 6 months, the angle could be highly variable. So we do these Fresnel prisms, and those prisms will alleviate the diplopia without the need to do a surgery. So for those patients, we don't do surgery unless the angle is stable. Okay. The third non-medical or non-surgical method is called the orthoptic exercises. So orthoptic exercises are based on the principle of expansion of fusional versions. This like you are asked the child to bring a pen in front of his eye and look it more to focus on this pen to bring it away and toward his eyes in order to train the medial rectus to stimulate the medial recti to be more powerful, to be more strong. So it will increase the fusional versions, increase the ability of the medial recti to do fusional versions so that it prevents the diplopia, which may result from the convergence insufficiency. So this can be also utilized as a line of management depending on the case. So it is very useful for convergence insufficiency, for cases of intermittent exotropia, as we just mentioned the last time, and also can be used for decompensating accommodative esotropia. Okay, so this is for the medical non-surgical management of patients with strabismus. So what are the kinds of surgeries that we offer for patients with strabismus? We have weakening procedures and strengthening procedures. The first weakening procedure, it is called recession. So what is recession? Assume that this patient has esotropia. So this esotropia means that the medial rectus is strong. So what can we do to improve this esotropia? We weaken the medial rectus. How do we weaken the medial rectus? We just remove the muscle from its original insertion and receding it backward, reinserting the muscle backward like that. So we are removing the muscle, disinserting the muscle from the old position and suturing it to few millimeters posteriorly. So this will result in weakening of the muscle action. So assume that this is the original muscle action and this is the original insertion. When you do recession for the muscle, this will result in that the muscle will become a little bit more redundant, more folded like that. So the muscle is not stretched, which will result in that the action of the muscle will be weak. So when the patient is trying to do medial convergence or to do adduction, this will result in weakening of the adduction, leading to alignment of the eye in the primary position. Okay, so this surgery is called recession. However, in some occasions, this recession can be a problematic issue because it will affect, especially when we are doing it in superior rectus or inferior rectus. This will result in that there will be diplopia because this recession will affect the muscle in all directions of gaze. So assume that we have a patient with fracture floor orbit and we do we do a superior rectus recession and then this patient didn't have diplopia in the primary position or didn't have diplopia in the down gaze, but you did superior rectus recession and you caused him diplopia in the reading position or the up gaze. So what will be the management? How can we just preserve? We just do we make the action of the muscle in the primary position, but we don't affect any other position. In this case, if we want to do so, we combine the recession by another procedure. It's called the posterior fixation suture. Posterior fixation suture or Faden suture. What is meant by the Faden suture? So assume again that you are doing a medial rectus recession. By the Faden suture, you are doing posterior scleral fixation suture. You suture the muscle posteriorly to the sclera. So what will be the effect of this? So you can see here, this is in primary position. The Faden does not significantly change the moment the moment arm. It will change the it will not change the axis in the medial and lateral positions. So here we do the Faden suture. And when the patient is looking medially and laterally, then there will be no problem. There will be no effect of this medial rectus. He can look medially and laterally normal, but it will just adjust the muscle position in the primary position. So So this will cause that the Faden suture will be very effective in preventing the diplopia in horizontal or on horizontal gaze or in vertical gaze. Okay. Is it clear? Okay. Another weakening procedure, it is called myectomy. And myectomy can be reserved for, or it is always reserved for cases of inferior oblique. So we do a myectomy for inferior oblique muscle in case of inferior oblique overaction, as in cases of esotropia, like infantile esotropia associated with inferior oblique overaction. So this is the inferior oblique muscle, and the inferior oblique muscle has a specific anatomical significance because you stretch the muscle between these two tools, and then you cut it from the basically you are doing this insertion of the muscle. You are just cutting it from the origin and insertion. But please be aware of that the inferior oblique muscle is just inserted around 1 to 2 millimeters from the optic nerve. So this is very important for you in order to avoid accidental damage to the optic nerve. Well, Dr. Ramia is asking, do we do a Faden in near or for far deviation? Actually, we do Faden for specific cases, like for example, if we have to reduce the convergence in a convergence excess esotropia. So if there is convergence esotropia, Faden procedure will be very beneficial here. And also we can do it to the superior rectus to manage the dissociated vertical deviation. So it will be related rather to the kind of error or kind of ocular misalignment that happens. So it has a specific indications. Regarding the strengthening procedures, we have the first and the most important one. It is called the resection. The resection is when we just cut a part of the muscle. So in here, in resection, we do cutting of a part of the muscle and remove it, and then suture the muscle into the original position. So again, in resection, we are doing cutting of a part of the muscle, then remove this part, and then suture the muscle into the original insertion. So what will be the effect of that? So assume that this is the resected muscle. This is the gray one is the resected muscle. You see how much the muscle is stretched? This is stretching in the muscle will strengthen it, making it more strong. So it will increase the action. So this is called the resection, removing a part of the muscle. So to compare between the resection and recession, like for this patient who has hypertropia of the right eye, what can we do for this patient? We do recession, resection. Recession of which muscle? Recession of superior rectus and resection of the inferior rectus. So for the inferior rectus, we cut a part of the muscle and suture it again to its original insertion. This will strengthen the inferior rectus to pull the eye downward. And we cut the superior rectus and moving it back, so and suturing it to the sclera, so we making it weaker. So again, this will align the eye in the primary position. So do you now understand when we said in the lecture what is meant by RR or recession resection? We recess the muscle that we need to weaken and resect the muscle that we need to strengthen. Okay. And that's why also it is very important to know what are the insertions of the muscles. Like the medial rectus is inserted 5.5 millimeter from the limbus, inferior rectus 6.5, the lateral rectus 6.9, and superior rectus will be the farthest of 7.7 millimeter. We said that in the anatomy, and we said that it has a significance in the surgical management of strabismus. So here is the surgical management, and here is the significance that when you know what is the normal insertion, you know how much you disinsert the muscle for recession, and you know also where is the location that you should reinsert the muscle in case of resection. Dr. Pragnia, is inferior oblique close to the macula as well? Yes, of course. Since it is close to the fovea, it's close to the macula. Okay, so here we can see the full procedure of strabismus when we are doing lateral rectus recession and the medial rectus resection for cases of exotropia. So for example, for cases of intermittent exotropia, we do lateral rectus recession and the medial rectus recession. So we do conjunctival incision, and opening the conjunctiva and the tenon capsule, expose the muscle. So here we are exposing the lateral rectus muscle, and then we take sutures, full partial thickness suture and full thickness sutures, double armed sutures, in order to fix the muscle, in order not to have slip the muscle. So when I cut the muscle will retract. So I just prevent them from retraction by these sutures. Then I will cut the muscle from this insertion, or from the insertion, which is called the disinsertion, and then suture it backward. So this is the original insertion, and now I am suturing the muscle backward in order to weaken the lateral rectus. So this is for the lateral rectus. Then we close the conjunctiva and tenon, and then for the medial rectus, again we hang the muscle using this squint hook, and taking our sutures, the full thickness and partial thickness sutures, to fix the muscle. Then we cut the muscle from its insertion, and now we cut apart from the muscle. We do resection of the muscle. Then we take these sutures to place into original insertion, and now we suture the muscle after cutting apart from it into its original insertion, so that we are now strengthening the muscle of medial rectus and correcting the intermittent exotropy. Okay, so this is how we do resection. Another procedure used for strengthening, it is called the advancement. So what is the advancement? It is as the name implies, we are just moving the insertion forward. Instead of making the insertion backward, we are moving the insertion forward. And this can be done for already recessed muscle. Like if the patient has recessed the muscle in the past, like if he had bilateral medial rectus recession for infantile esotropia, and unfortunately it turned out, or it was followed by consecutive exotropia due to over recession of the muscles. So actually the patient's problem now is the consecutive exotropia. It is due to operative problem, which is over recession of the muscle. So the treatment of choice here is just we take this over recessed muscle from its backward insertion and move it forward in order to reinsert it more forward toward the limbus. So this will improve the action of the muscle and will correct the consecutive exotropia, making the eye aligned in the primary position. Okay, so this is for the advancement. Another procedure used for strengthening, it is called tucking. So tucking is usually reserved for cases of congenital fourth nerve palsy because it is used for the superior oblique. So what is meant by tucking? It is just like plication. This plication of the tendon can be done for the tendon or for the muscle. So this is the trochlea, this is the superior oblique, and the superior oblique tendon. And we do just a tucking or making the muscle folded or the tendon folded on itself, or plication. This will result in strengthening of the muscle. So we do this for cases of fourth nerve palsy. Another procedure that we mentioned that is used for paralytic strabismus, especially in the sixth nerve palsy, is called the transposition. So what is meant by transposition? We do splitting of the muscles like superior rectus and the inferior rectus. Then we transpose the medial part of the inferior rectus and the superior rectus into the medial rectus, and transpose the we transpose the lateral part of the inferior rectus and lateral part of the superior rectus into the lateral rectus. So this will keep the eye a little bit aligned in the primary position by changing the axis of the horizontal muscle action. So we just we implant the muscles at areas of weakness or at areas of paralyzed muscles, and this also can be used for cases of Duane syndrome and also cases of alphabetical pattern. So what is meant by alphabetical pattern? This name we mentioned in during strabismus lecture. We said A pattern and V pattern. So let's try to understand what is meant by A pattern and V pattern. So V pattern or this V pattern, when the eyes looks deviated or more convergent in the down gaze than the up gaze. So this patient has less convergence in down gaze, and when he looks up, the eyes looks more divergent. So when you draw a shape of the eyes in the up gaze and down gaze, this is called the V pattern. The reverse, if the patient has A pattern. The A pattern is when the deviation is more convergent in the up gaze and more divergent in the down gaze. So when you draw these eyes, the pattern of the eye movement, it will draw the letter A. Okay, so usually the V pattern is due to the inferior oblique overaction, and A pattern caused by the superior oblique overaction. So how can we manage? How do we treat the V pattern and how do we treat the A pattern? And for those who are applying for the advanced ICO exam, this question appeared for this exam particularly. So a V pattern esotropia, how we do manage? If the patient has esotropia associated with V pattern, like the patients with infantile esotropia, we do bilateral medial rectus recession as like the normal management of esotropia, but we just do downward transposition. So we weaken the medial recti by recession, but when we are trying to reinsert them backward, we just make them a little bit downward. This will correct the V pattern. And if the patient has V pattern exotropia, so the standard surgery will be bilateral lateral rectus recession. We are weakening both lateral recti, but we do upward transposition. So the lateral rectus, when we do recession for lateral rectus, we reinsert it. So we just placing them a little bit up, upward transposition of the lateral rectus. The reverse is to do in the treatment of A pattern. So for the A pattern, the eye more esotropic in the up gaze and more exotropic in the down gaze. So how do we correct A pattern esotropia? We know that we do correct the esotropia by bilateral medial rectus recession. So how can we correct the A? We just do upward transposition. We are moving the muscle a little bit upward to correct the esotropia. For the A pattern exotropia, we do bilateral lateral rectus recession and downward transposition. So if we work on lateral recti, we do transposition inferiorly. So you got confused? No problem. So how can we remember it? We remember it by the word male. What is the reference of the word male? M for the medial rectus is toward the apex, and the lateral rectus toward the edge. What is meant by that? What is this mnemonic, strange mnemonic? Medial rectus toward the apex, lateral rectus toward the edge. medial rectus toward the apex of the A or the V, and lateral rectus toward the edge of the A and V. So medial rectus toward the apex. If I'm going to do medial rectus recession, I am going to transpose the muscle toward the apex of the V, which will be here downward, and the apex of the A, which is upward. If I'm going to do lateral rectus recession, I am going to transpose the muscle toward the edge of the V or the edge of the A. So edge of the V will be upward in case of the correction of V pattern, and the edge of the A will be downward in case of A pattern. Okay, easy now. Can you please explain again why the inferior oblique muscle cause a V pattern and superior oblique pattern is because of the inferior oblique for extorsion? Yes. So if there is inferior oblique overaction, the inferior oblique is elevator, and also it causes abduction. So when the patient looks up, it will cause elevation and will cause abduction. So the eye will be more deviated in the up gaze. The reverse will be in the A pattern. When the patient looks down, the superior oblique is a depressor, and it will cause abduction. So when the patient looks down, it will cause depression and abduction, leading to more deviation in the depression or in the down gaze. Okay. You are welcome. Okay, so finally, the last line for management of strabismus will be the botulinum toxin. So what will be the idea of botulinum toxin? It will cause a temporary paralysis to the extraocular muscles. So we inject it into the extraocular muscles in order to temporarily paralyze it. So what will be the causes, or what will be the most cases that will benefit from the botulinum toxin injection? It is usually helpful in the small to moderate exotropia and esotropia, which is less than 40 prism diopters. Because more than this, it will be unlikely that the injection of the muscle will be effective alone. It's also very useful for patients with active thyroid disease. If the patient have decompensated thyroid and his thyroid state is uncontrolled, so he needs some temporary measure. And also used for the strabismus surgery in the thyroid is one of the most unpredictable outcome. So it is very common that those patients will present with post-operative diplopia. So how can we correct this? We correct this by not by doing we can correct this by different methods. We can do what's called adjustable sutures, and another way is to do botulinum toxin injection into the muscles. So this will be the main effect, or like if you have multiple choices, ask you which one of those will be the most beneficial for botulinum toxin. It will be the mild to moderate exotropia and esotropia, thyroid, but it will be less helpful for A pattern and V pattern, dissociated vertical deviation, or oblique muscle disorders. And success has been ranged from 30% to 70%, depending on the size of the deviation. Okay. Okay, so this will be the end of strabismus. Any question?